Hi guys. Brian. Hi guys.
Hi.
Thank you. Alan, is your camera on?
Yeah.
Okay. Okay, so today we have Alan Truong, whatever PGY3, who just did a fantastic testimonial on short rounds, by the way. Thank you for that. Who's going to be speaking about the placebo effect, the secret ingredient. Take it away.
Welcome everybody. Thank you, Sandrine. So that is my middle name. I am a doctor from PGY3 at this hospital. I did my medical training at SUNY Downstate, not too far away, and I went to undergrad in California, where I had a psychology degree. And I'm going to be a primary care ambulatory internist next year. Thank you. So the placebo effects. So you might be wondering right now, what kind of topic is this? You must be very excited, or not. And is this going to be board relevant? Is this going to be useful? We'll see. But the bigger question is it going to be useful for your life? That's the biggest question, and the answer is yes. But you might also be thinking, are placebos, aren't they just annoying and deceiving? And so some of these are some questions that I had when I was preparing this topic, and you're probably confused, and even these pills are confused. So let's get started. So first, just want to say it's a very hot topic. You know, it's in the news, New Yorker, Time magazine, New York Times. You know, everyone writing about it. There's been a lot of interesting research lately in the last few years. And by the end, I hope you have a better understanding and appreciation for the placebo effect. So an overview. First, we're going to go over a little history a little bit. We're going to define it, reconceptualize it for the modern era. Then we'll see how it works mechanistically. We'll look at possibilities for clinical application and look at some of the ethical implications. So the word placebo really dates back to when they were trying to translate the Hebrew Bible into Latin. This man named Saint Jerome, he was translating a phrase that said, "I will walk before the Lord." And instead, he put placebo domino in regione vivorum, which the placebo meant "I will please." So that's where it came from. Then the first physician who used this term in 1763 was Dr. Sutherland, who talked about placebo in the context of using water as a cure. This phenomenon was demonstrated a few centuries later in the Michael Jordan documentary. Bugs Bunny. It was really Dr. William Cullen that gets the credit as a physician who introduced it in his clinical lecture series in 1772. He described using a placebo treatment as given to a patient whom he regarded as absolutely incurable, hastening to his fate. So he didn't have much hope to cure the patient, and at the very least he wanted to employ a placebo treatment to comfort or to please the patient. And some examples of things that doctors in that time used: for external medicine, they might have liked to use mustard powder, which could stimulate things. And then for internal medicine, like dysentery or fevers, Dover's powder up in the top left. And this had some opium in it, so we no longer use it. His main concern was not what he was using, but fulfilling the patient's desire for a remedy, even though he didn't always believe in its effectiveness as a medication. And placebo effects really started to get more into the mainstream after World War II, when randomized controlled trials began to be popular. And they always, of course, put a placebo arm with the active treatment arm. So this says, "Hey man, our trials show that the new drug performs no better than placebo. So most of those guys are so disappointed. But this guy is smart. He's the man of the future. Maybe we should look more into what the placebo effect really is." Because they found that actually placebo effects did do a lot of good for the patient compared to the ones who got nothing. So what's going on here? Dr. Henry Beecher in the 20th century wrote about the powerful placebo. He has my birthday, so I'm an appropriate presenter for this topic. And basically he saw that about 35% of patients respond well to placebo treatment. However, research into placebos didn't really take off till more recently because people were more focused on the science of the active drug, and he didn't really separate placebo response from confounders. So now we're going to define it a little bit. So what is the placebo effect not? Well, these are some of the things that may go on in the placebo arm of a trial. You know, they might be the natural course of the disease, like a viral illness. You're going to get better on your own, even if you gave something else. Regression to the mean. This is just a statistical phenomenon where sometimes you get some data that's higher or lower than others, and it'll regress and average out. Sometimes their symptoms will just fluctuate, and a lot of trials go, you know, you have a subjective response, you know, so they might have a bias there. And in some of these trials, they're kept on some of their treatments, like kept on some of their IBS medications, kept on some of their pain medications for back pain. So it could just be a response to those things. And so these are not really part of the definition of placebo effect. So when you look at the dictionary, they really focus traditionally on the placebo's inert content. They talk about, you know, it could be a lactose or sugar pill, pharmacologic placebo. You have a physical placebo like a sham surgery, a sham procedure like sham acupuncture. Psychological placebo, kind of looking into, you know, interaction with the patient. So the association with randomized controlled trials has caused some confusion, and because look at it this way. So they say that the placebo effect is an inert substance or procedure that does nothing, right? Placebo effect is there followed as it's a phenomenon that follows the administration of the placebo. So if you do simple math, like how can something that has no effect have an effect? It doesn't make sense. So they really got to reconceptualizing it to involve kind of the clinical encounter as part of it. And we'll discover during this talk that every medication, whether it's something real, like an antibiotic or something like a sugar pill, they'll always have some form of placebo effect in addition to their specific drug effect. Just a few other definitions that are kind of mixed, people don't really agree on, is pure placebo or inert. You know, it's really a placebo, that it doesn't have an effect of its own. Can also include like a little saline injection. Impure or active placebo can be like vitamins that you give to people, or like antibiotics that you gave for a viral illness, or something where it has an effect but it's not actually doing what you mean it to do. And ultimately, finding the definition for placebo isn't really focused on these terms. It's more about what it's actually doing to the patient. So accumulated research in the last few 10, 20 years, led by this man, Ted Kapchuk at Harvard, has reduced it to kind of this general idea that a placebo effect is a genuine psychobiological event attributable to the overall therapeutic context, meaning that it's not just what you're giving, but it's also the psychologic and the biologic aspect. So just teasing it out like a math equation, placebo effect is the result of the placebo intervention, like we're saying. So the placebo itself, like the pill, plus the therapeutic context, that can be further subdivided into the psychosocial context and the clinical interaction. The psychosocial context is always there with us, in me, in the patient, and it's really talking about individual patient and clinician factors like our own belief systems, our past experiences, our desires for what's going to happen in the encounter. And then the clinical interaction, doctor-patient relationship, you know, our empathy, bedside manner, how we reassure the patient, and the treatment environment. How did we give the treatment? Did we give the pill by injection? Did we give them a pill? Or did we give them a surgery? Or like, what's the interaction? And this is kind of a fancy plot that talks about what I just said. On the top, it's just saying that when you administer an active drug, or if you're giving a placebo, they both are interacting with the psychosocial context. And so just going back to the definition, it's just important to understand this type of conceptualization so that we can harness the power of the secret ingredient of placebos to our favor. Just briefly, I took out a bunch of slides, but the nocebo effect is generally the opposite thing. It's when you give them something, but that they have these expectations, negative expectations, that they'll start to feel like worsening harmful side effects when it in reality was inert. Some examples of this, briefly, are the rise in gluten intolerance. Everyone's afraid of gluten. Everyone thinks they have celiac disease, but before they go get diagnosed, they're already feeling, oh, I'm eating this bread, it hurts. I don't know, I gotta avoid it. And then when they go to get diagnosed, a lot of them are not having celiac. And then there was also this other trial about statin myopathy that looked at how a lot of statin myopathy might actually just be this placebo effect, because they did like blinded and non-blinded arms, and so it was interesting. But I'm going to focus on the placebo effect going forward. So I mentioned this guy before. Who is this man? He looks kind of curious, He's, unlike the other men, he is still alive, which is good. So he's actually the only professor at Harvard who didn't have formal medical training. He went to undergrad at Columbia for East Asian Studies. He went to Macau in China to get a degree in traditional Chinese medicine. He wrote a textbook on it. And acupuncturalist, herbalist guy. Harvard took notice of him, and they were like, why don't you come over here to America and be our Eastern medicine specialist? Part of this orientation was we got to teach him how randomized control trials work, how medicine works over here. And then he was like, whoa, whoa, whoa. What is this placebo effect part? It seemed to be so prevalent, and especially in like acupuncture trials. So he switched his career to study placebo effects. He did a TED talk on it a few years ago, which does a good job of condensing this talk into 15 minutes. And he's really trying to harness like an understanding of placebo mechanisms to see if we could use it for our benefit in clinical practice. So some of the mechanisms of the placebo effect. So it divides into psychological and neurobiological categories, just like our previous definition said. So going over psychological mechanisms, this was my area of expertise 8 years ago or something, but I had to review it. Essentially, there's two main areas that have been well supported: expectancy and classical conditioning. There's also some other categories like learning or memory, reward, that I'm not going to really touch on because these are the main two. And first, expectancy. It's the idea, pretty common sense. When you're given a placebo, patients expect a future response to what they're giving, so they expect something's going to happen. And in some trials when they did this, they would give simple verbal cues as an example of to promote expectancy or not. And an example, very simply, is like, your arm hurts, I'm going to give you this cream, it's going to be a powerful painkiller, versus telling another person, this cream's not going to do anything. So that's kind of an idea of expectancy. And this is an example of a study that they did that investigated the role of expectancy. Essentially, it was randomized double-blind study with 60 healthy volunteers, and they measured how long they could tolerate pain, or how long they could have a tourniquet on their arm before it just hurt too much. So each of these groups, the first group just got no treatment throughout the 5 days. Groups 2 and 3 got an injection of normal saline on day 2, and one group was told, this is a pain medication, you're going to feel better. The other group said, hyperalgesia, this is going to hurt. I'm giving you something to make it hurt. Okay, and then group 4 and 5, similar thing, but they both got ketorolac on days 2 and 3, and then had the same normal saline injection with the same suggestion of this is going to hurt, this is not going to hurt. The results, not surprising, group 2 that was told that this is going to relieve your pain did better in their subjective pain improvement scales. Same thing with group 4, did a lot better when they were told that you were given something good, and the pain person was like, ow, this hurts, even though it was the same normal saline. Classical conditioning, I'm sure you're all aware. This man named Ivan Pavlov, a Russian physiologist, did his famous dog experiment. I always loved this idea because my college was named UCR. But anyway, the idea is, you got your unconditioned stimulus that will always make you salivate, unconditioned response. You add your neutral stimulus, and then you pair it together, and then after a while, you come back and the bell is going to make you salivate. So basically, this is a chart that shows the relationship between expectation and conditioning, how they found that expectation that we described before has more of an effect on conscious, subjective processes like pain or motor performance, whereas we're talking about conditioning now. This can actually touch on some unconscious processes like hormone secretion or immune responses. This is an example of conditioning for immunosuppression. So they did do a study in which they found they could condition immunosuppression in rats. So this was the first one with humans. They did a double-blind, placebo-controlled study with humans, and in 2 groups, basically over 3 days, they did 4 administrations of either a placebo pill, like a sugar pill, or this cyclosporin A, immunosuppression. You could think of this as unconditioned stimulus because an immunosuppressive drug is always going to result in immunosuppression, whereas placebo won't, right? So they paired it with a flavored drink every 12 hours. And then a week later, they measured the responses back. And basically, this was the immunosuppressive response as measured by IL-2 and interferon gamma mRNA expression. And they showed that for giving cyclosporin A, they're going to be immunosuppressed here. And then later on, when they only gave the placebo pill with the flavored drink, they were still immunosuppressed, which is pretty interesting. And this is just to say that the relationship between expectation and conditioning isn't so clear. They're still doing studies on it, and they've found that they've suggested that conditioning might be following expectation, which bottom line says the first encounter is very important. When you set up the expectations, it may help lead to the conditioning later on. So just think about this the next time you go on a job interview. When you're prescribing a treatment, make sure don't be willy-nilly about it. You know, be confident and worthy when you first meet your patients. Make them feel the rapport. And when you go on a first date, it's important too. So neurobiological mechanisms. There are a lot of different mechanisms in which placebo effects can occur. This can occur in healthy people like you guys, or in patients with multiple comorbidities. And we can separate these into pain-related or non-pain related mechanisms. There's a whole chart here. A lot of studies have gone into placebo analgesia for pain response, less so with other responses, but they have done it. First, just the pain responses. This can involve more than just endogenous opioids and dopamine. Can also involve the cardiovascular system, like through placebos, they've shown that we can beta block our heart without a drug, found that we can condition the respiratory center of our brain to breathe slower. And this is just to show that in a lot of these mechanisms where you can use real drugs, like beta blocker, anti-Parkinson, you can also use expectation or conditioning to have similar responses as well. One example here I just want to point out is cholecystokinin, CCK. It mediates the pain response, so when you have more CCK, you get more pain. And patients have been treated with CCK antagonists and reported some analgesic effects, and they've also been able to show through conditioning and expectation they could do some of that too. And some studies showed that some of these responses can extend beyond just the pain pathways, which I described with beta blocking and respiratory centers. So I separated out, these are the non-pain responses. They're not as well understood, they're still doing a lot of research, but it's very interesting that they could use placebos to activate some dopamine to initiate, like similar responses for depression, anxiety, addiction, and we've talked about kind of the immune before and conditioning some hormones too. But that's a little bit out of scope of this talk because it could go on for a long time. So yeah, this kind of just goes over what I just mentioned, but one thing I wanted to mention is that interestingly, patients with dementia, they found that even though they've found some sort of responses in Alzheimer's disease with executive control, functional connectivity, they've also found that they haven't had as much of placebo responses in these patients. They don't have as much awareness, they can't respond as well to verbal cues or expectation. Like if you tell them, sir, Mr. So-and-so, this cream is going to work for you. And he's like, 1979, you know, like he's not going to respond as much. So interesting. So now that we've looked at some of the mechanisms, we can look at some of the possibilities for applying this clinically. So a lot of these studies have gone into, involved randomized controlled trials, had some flaws. A lot of them don't go into a completely no treatment group. Most of them are placebo versus the drug. So in a lot of those studies, it was hard to analyze in the past what the placebo is really doing. And so in the last 20, 30 years, there have been a lot more trials coming out that compare placebo with no treatment. And this was kind of an alarming finding in the New England Journal about 18 years ago. Is the placebo powerless? What they found was, yes, in a few small trials, there was some benefits for the treatment of pain, which was statistically significant. But otherwise, overall, they were saying that, look, there's no placebo effect. It's kind of overblown. It's really just the natural disease course and all these fluctuation in symptoms. So there was a lot of backlash from the placebo research community. They did admit some of their own limitations. They admitted they had some of their small trials they looked at had some poor methodology. And as we've kind of seen, like, there's so many different placebo mechanisms that when they group them all together into binary outcomes, yes or no, versus subjective outcomes, like, it kind of muddies the whole thing up because it's hard to really compare placebo mechanisms. They did not review the effect of the patient-provider relationship, which is so central to this concept that we're bringing out here. And they didn't really separate the methods. Like, for example, there was a study that they did with someone with chronic pain of the arm, right? And they gave these patients a pill, it's half of them, and half of them gave them sham acupuncture. And what they found was the pill made them sleep better. Acupuncture made the pain better overall. So if placebos can do different things, then how can we really say overall that placebos don't have a natural, are only due to natural history? There's differences, so more research has been done since then. So I'm going to move to a kind of a few interesting trials that illustrate this concept. This was by our friend Ted Kapchuk from Harvard. He looked at patients with IBS, which has a lot of subjective outcomes, like, is my diarrhea getting better, like feeling more comfortable, abdominal pain, such. And he randomized them into 3 groups. He kept them all on their IBS medications as a control as long as the medications were stable, no lifestyle changes recently, no change in the doses. The first group of patients, he had them do sham acupuncture, on a table, which I'll explain in the next slide. And the provider was also pretty loving, used a lot of empathy, listened to the patient, asked them how they're doing, and say, I can understand how difficult IBS is for you, stuff like that. The second group got the same quality of sham acupuncture as their placebo procedure. The provider didn't talk much, just kind of did their job. The third group was like, what's going on here? When am I going to get started? No treatment, just on a waiting list. And just real quick, sham acupuncture has been used in a lot of these placebo trials. The idea is that real or verum acupuncture punctures you for real in the skin. The placebo one uses a blunted needle that doesn't penetrate the skin, but gives you the sensation that your skin is penetrated. This is the dermis and epidermis. This is the real needle going in. This is the sham one that just kind of presses it down. The results were not too surprising, but pretty cool. The augmented group that got the love and the sham acupuncture generally did much better. The one with just sham acupuncture did better than the waiting list. So it was a graded dose escalation kind of feeling here. And it showed that the therapeutic relationship itself can add a layer to the placebo effect beyond just the procedure itself. This was an interesting one because some of the best evidence out there for placebo effects is from surgeries. And this was one of the first ones where a group of orthopedic surgeons looked at a bunch of patients with osteoarthritis of the knee. I don't think they went out to prove the placebo effect. They were really trying to see how effective is our surgery. They had 3 groups. One was, they were randomized into debridement, arthroscopic lavage, and placebo. So the placebo group, they took the same amount of time with the surgeries. They did the same kind of sedation, they did an incision, and they splashed some water around, talked as if they were still doing surgery in case the patient remembered anything. So they compared all three, and basically they found that there was no statistical significance in the objective walk scores or 5 subjective scores at all. And that was very interesting. Some of the limitations were that it was a study done at the VA, so mostly men, and then also, the patients had informed consent that there was a 1 in 3 chance they might get a placebo surgery. So people who dropped out may not have had as much hope in it. People who stayed in may have had more hope in it. But they've done some more studies on sham surgeries which have showed similar responses. This is a review of randomized controlled trials that they tried in oncology patients. Essentially, it looked into what can placebo do, what can placebo not do. And what they did find was there was an improvement in the pain levels in 2 out of 6 trials, and appetite in 1 out of 7 trials. But overall, they found that you couldn't shrink the tumor, couldn't get better performance status or weight gain or quality of life in their scores. So, we're not here to say we're going to replace all drugs with these placebo pills at all, but there might be a role for placebo treatments in patients that do have objectively measurable outcomes like cancer or heart disease. They're going to have some depression, they're going to have some subjective pain and emotional things that we could possibly address. And who knows, maybe it's something palliative could offer in the future if this gets more established. And one of the most strong and convincing supporting evidence of placebo effects in trials is called the open hidden study design. This is basically adding a different arm to your clinical trial. Instead of just having your placebo arm and the active treatment arm, we're adding this hidden dose arm. So just to explain, because it was confusing at first, let's say you're investigating a drug like IV morphine or some sort of opioid, right? Up here, there's always going to be an active treatment specific effect where they're getting the morphine and the morphine will act. Now, if you're giving it in front of them, the nurse says, I'm going to give you some morphine now. They know about it. There's going to be a non-specific expectancy conditioning effect on the outcome. But imagine if you do a different arm where you set up a pump, a pain pump. You tell the patient, you're going to get this morphine, but we're not going to tell you when. So they know they're getting it at some point. The active part of the drug is still there, but you remove that factor where they know they're getting it right then. They don't know when they're getting it. So if you take this top part and you subtract the bottom part, you can isolate better the actual placebo component of the treatment, where only the knowledge about the treatment comes to the outcome. And just to illustrate this in an example, in the 90s they did a trial looking at a cholecystokinin antagonist, and if you just look at it simply, it said that this drug was better than placebo. Okay, so that's great. But they also did a hidden arm where they would give this medication without the patient's knowledge of when, like through a pain pump type of thing, and that resulted in no response. It had a response, but it was no better than placebo. So when they got the dose in a hidden dose, it was no better than placebo. So it showed that this drug actually wasn't as good as they thought. It only had a good effect when the patient knew about it. So this could be a useful tool when doing some studies. All right, so that's enough for the trials. Let's look into the ethics of how can we do this, even if it's good. How can we give patients placebos? Is it ethical? So there was a survey back in 2008 asking some internists and rheumatologists from America about their placebo use. And it was a pretty simple survey. They didn't really ask what kind of sedatives, what kind of antibiotics or anything, but 41% showed that they did use over-the-counter pain medications for non-specific complaints. They used over-the-counter vitamins in a lot of cases, not just because the patient was on one, but because I'm coming with fatigue, okay, I'll give you a vitamin. Antibiotics, like for a viral illness and such. And then very few actually use saline or sugar pills. That's probably our placebo researchers answering the survey right there. But about half of these doctors said they used placebo treatments regularly, which is a lot. and about 2/3 of them thought it was ethically permissible. So some of the ethics. So I looked at a few ethics articles and condensed it to these main 3 questions. Do we know about clinical placebo effects enough to use them? And I think that's always central to these kind of questions, is like, if you don't know enough about something, how can you recommend it? So of course we're doing a lot of studies still to look more at the utility of it. Can we ethically recommend a treatment mainly to produce a placebo effect? So we know that, deceiving anyone is always not good. They say that if you deceive a patient to do a placebo effect, then it violates informed consent, threatens trust, so it's not good. However, it follows that how can we promote them without deception? And ethicists do agree that it's ethical to frame something positively, to promote positive expectations, to have a supportive encounter. All that is ethical as long as you're not misleading them or deceiving them. Okay, that's great, but what if we give patients a placebo and tell them it's a placebo? What about that? That sounds nuts. But that's what they're doing. Is a lot of trials are looking into this, especially over at Harvard. Placebo can work even when you know it's a placebo. And it's this concept called the open label placebo, introduced by Ted Kapchuk, that same guy from Harvard. He did a pilot study December 2010, also in patients with IBS, but in this time he changed it around and said, I'm not going to hide the fact that they're placebos anymore. And this resulted in, they found that it showed a significant improvement in subjective IBS scores in the placebo group compared to the control, which is a no treatment, which is pretty cool. But how did he do this? Like, did he just give them a pill and be like, this doesn't work, but I hope it does, And so this is a cartoon because it's kind of a joke, because like a lot of doctors are prescribing what we think are placebos, but it's not a joke anymore. This is literally what he did. The group that got the placebo pills were given a bottle clearly marked placebo pills, take 2 pills twice daily. So it's real, and they looked like this. It was filled with a common inert ingredient called Epicel. So he had about 40 patients in each group, 40 patients that got the placebo pills, 40 patients that didn't get anything. But what they both got was an informed consent before the trial started. They both were told 4 main discussion points that essentially focused on a warm, supportive environment and supported them that they were important to this trial. So the 4 discussion points were: 1, placebo effect is powerful. Okay, like it's been shown in trials to have good effects. 2, the body can automatically respond to taking the pills like Pavlov's dogs and get conditioned. 3, having a positive attitude in this trial helps but isn't necessary. And 4, if you're in the open label group, then it's critical that you take the pills faithfully and take this trial seriously. And they also told the other people, you are important to this trial too. Like they didn't discount them or anything. And overall, they wanted to frame it positively. They wanted to optimize the placebo response. But as you can see here, none of this is unethical because they're being very forthright about this. They're not lying about the trials and everything. So the results. These are some of the 4 subjective scores for IBS. 3 of them had statistical significance, and the 4th one, quality of life, was approaching statistical significance with 0.08 p-value. But essentially, it showed that these people that got a pill that they knew was a placebo had better outcomes than these ones. And you can think of, how did this happen? Did they not understand what a placebo is? Did they think it was real? So they did do a post-intervention kind of questionnaire, and 12 people said it was sugar. They thought it was sugar. 3 said flour, 1 maybe calcium, 6 said nothing, 1 said symbolic reminder, and 1 said possible test medication. So there was not really a problem with education. They knew what they were getting. And maybe a limitation could have been like they were recruited in such a way. The recruitment poster said something like, you're being recruited for a novel intervention that might help with your pain. So it might have attracted certain people that were more likely to seek out certain things. But overall, they did find that yes, it can be effective and without deception, which was pretty interesting. So some future directions on this open label placebo, when are we going to see it given in the ED or in the ICU? Well, not anytime soon, but shortly after that first trial, they did a telephone survey of a bunch of patients. They told them all about the trial and everything, and 62% of them gave a probably or a definitely would try it. So I don't know which one was definitely, like if it was only 10% definitely, but a lot of people were willing to try it out. And just quickly, just touching on some of they've done a few more small trials on this, 2014 on migraines, 2016 on low back pain, last year on cancer-related fatigue. All of them had about 60 or 80 N value. So it's promising, but the researchers do recognize that a series of small trials could be followed up by a large-scale trial that fails. So right now they're getting ready, or they're in the process of carrying out their large-scale trial on using open-label placebo. And they kind of conclude, in the future directions, saying that it could be a possible future supplement to intervene in some chronic diseases. You can use it as an adjunct instead of just watching and waiting. Give them something, but not be deceptive about it. Just touching really quick on complementary and alternative medicine acupuncture. I'm not going to go into this in depth because Dr. Shah here already went through it. But one of the examples that they used in discussing this ethical concept was acupuncture. They cited this review that looked at 4 large clinical trials, patients with headache or low back pain, and they compared Virum acupuncture, or that's the real acupuncture traditionally trained, to the sham acupuncture that we discussed, to a usual care control, meaning they would be still on their NSAIDs or watching and waiting. But long story short, they found no significant statistical difference between the sham and Virum groups, which suggests from this review that true acupuncture is mainly acting from placebo. But both groups were better symptom relief than the usual care group that didn't get it at all. So, and then the most interesting thing they found was that expectancy, or like having high expectations, they would ask them, do you have high expectations or low expectations? Having high expectations that it would work out was the most reliable predictor of pain relief. Now, I'm not trying to discredit acupuncture or anything. There are a lot of trials out there that say it's good. I'm just using this as an example of when you have seen data that something is a placebo, is it ethical to recommend it? So it is kind of controversial whether it works or not, but these ones show that it didn't. But the central idea I'm trying to get at is, if I know something performs no better than placebo, is it ethical to recommend it? And basically yes, but don't deceive them, give them some informed consent. And using acupuncture as an example, if you're using these trials, they gave an example of how you might want to portray it. But it would be kind of lengthy, and in real clinical practice, they probably ask a million questions. The idea is, I recommend you try acupuncture, kind of describe that it works by a psychological mechanism, talk about the placebo effect, about these trials, and then with that said, I think it will work very well for you, is an example of what you could say. You could substitute this with some over-the-counter remedies and things like that, if you want to be true 100% ethicists. So this is coming to the end here. That was all fun and games, but what can we take away from all this? Because there wasn't any mix-up questions I could find. I think this is more of a life lesson. So placebo effects are real, they're complex, and they're clinically relevant, and we should study them seriously and not just brush them to the side. When a lot of people ask Dr. Kapchuk about his research into placebo, they're like, what is this? You're studying trickery, deception, but he's studying something real that he thinks can help people in the future, studying humanism and everything. Also, when you hear that a treatment is no better than placebo, maybe take a step back and don't discount it right away, because placebo can be pretty good, and a lot of these alternative therapies might only be working like placebo, but placebo can work for these people. And as long as it's safe, you can recommend it as long as you're not deceiving them. It also emphasizes that randomized controlled trials are important. Placebo can give a good comparison to the active treatment. You can use the open hidden study design to find the role of the placebo in the trial a little bit more. And I think my final point is the most poignant, that made me all emotional. I'm going to primary care next year, and you can give drugs all you want, but the clinical encounter is very important. I'm beating a dead horse, but it's very important. If patient satisfaction scores are more than just for reimbursement, it can help with clinical outcomes, it'll build rapport, but they might actually do better from the drugs you give them. Like if you nervously give them I'm going to give you this medication, some trials, I think it works. It's not going to work as well as if you present it confidently, as long as you're not deceiving them. I had a dream about this. That one day, I had a dream about being in a patient's room, and I was just so excited to take care of the patients. And I came to Queens with Dr. Mazurkis the next day, all excited. I was smiling, taking care of the patients, and of course didn't try to take forever, but it was a good day. And I feel like carrying that forward is good for the patients. They'll do better overall if they like you, and they'll do better with whatever you give them. So remember to teach back. Remember to complete SNOW, do the discharge summaries at bedside, ice the patient, cultural competency, Peabody curriculum. It's all good. Make the discharge appointments so that the PMD, so I can see it and give a good transition of care. I'll appreciate next year. Your patients will too. This is some references. Thank you.
Thank you, Alan, for your very entertaining lecture. You guys have any questions?
So Dr. Ketchup, that was the guy from Harvard.
Yeah.
Where were you finding patients? Were they at a hospital and you would visit them, or were they people seeking a clinic like his out? Because if there's people seeking out like Eastern medicine and acupuncture, and they go to his clinic, maybe they already have like a psychosocial bias towards these things, and they're probably more open to it, and they'd probably do better. Was that, or did he go to the hospital and he found like patients with this diagnosis, and how was that?
Also, thanks, Vinny. So the question was, where did Dr. Capture get these patients, whether they were in the community, in his clinic, or in the hospital? I didn't research him that extensively. I did watch his TED Talk, but it seems like he's totally focused on his placebo research. He didn't talk anything about seeing his own patients anymore. And as far as recruitment, it looked like in those trials that it was kind of an open recruitment to the community more, but some of those other trials were definitely inpatient that weren't always his. So.
Dr. Freed.
The gold standard for cause and effect is things like dose effect. If you give more, is there more of an effect, or dividing up patients according to the severity of their illness? Do you get a certain amount of effect in the mildly ill, and a certain amount of effect in the moderately, and then the more severely ill? I was just wondering if any of these studies took a scientific approach to figuring out a real cause and effect relationship.
Thanks, Dr. Freed. So like in terms of open label placebo trials, at least those 4 that I looked at did not stratify by severity of illness. However, like they have done other studies in placebo effects that looked at you could find like different layering of placebo effects in different patients, and a lot of different mechanisms in them. But yeah, I didn't see anything like that specifically. It might be there. There was just so much research, and it's a very big topic that I could look into that for you.
I have a question.
Yeah.
Were you going to ask him about that? Oh, go ahead.
Doctor-patient interaction also as reassurance by a doctor as I don't want to call it placebo, but I remember my encounter as a child when I was nauseous and But, so how much that interaction in the setting of clinical trial, because if you're in a clinical trial, then you placebo, you still have multiple visits. So how could you just for that, that even if you're going and not getting anything and lying down on the table? So it's very, really difficult to tease out this interaction with the healthcare system itself may have some effect. You get what I'm saying?
Yeah.
And how you can tease that out as a factor on top of everything else we're doing. Because then it brings it back to patient satisfaction also. That also, the fact that you like your doctor and don't like your doctor. Because one of the things that you pointed out, that patient satisfaction is important because it has, patient is satisfied has a better effect. At the same time, we have data that shows patients who are more satisfied usually have worse outcomes. So the outcome and patient satisfaction scores don't work together. So all I'm saying is it's very complicated and it's very provocative, all this new data about placebo. And you did a great job, thank you.
Yeah, thank you. So Dr. Ahmadi is asking about how do we tease out the kind of all the clinical interactions with every trial, and then the controversy over patient satisfaction scores not always correlating with great outcomes. So that's a great point. I've heard of that before. I didn't actually go I didn't look at the disparity between patient satisfaction scores and outcomes, but definitely we're not always trying to please our patients just to please them when it's not the right medication, of course. And then I did mention there were like that trial where they did the acupuncture without much talking, and then with the warm encounter where they were talking to the patient definitely showed that there was an increased effect there. So I'm thinking that a lot of this new placebo research is starting to permeate out there, where researchers are starting to look a little bit more about the clinical encounter separate from the ones that don't have it as well in like different arms, whereas in the past we wouldn't have done that as much.
My question was, aside from IBS, do you know if they studied any more other medical conditions like fibromyalgia for the placebo effect?
Oh yeah, well, so they definitely, you mean for the open label placebo?
Mm-hmm.
So he did do 4 more trials after that with a very similar study design with migraines and low back pain and cancer related fatigue. And there may have been other trials outside of just him, but these were some of the examples in recent days.